to go over the public health response to meningococcal disease. Could I have the next slide, please? So we'll go over the epidemiology in Australia, and then we'll have a look at the disease control guidelines and look at the response to single cases, but also look at special situations such as cases in childcare centres and in Aboriginal communities. Next slide, please. So before we get started, I'm sure many of you have worked with meningococcal disease already, but just in case you haven't, so Neisseria meningitidis is a gram-negative diplococcus, and it only lives in humans, and well, it requires humans to live, so it doesn't exist in the environment. It's said that there are 13 serogroups, but A, B, C, W, Y, and X cause most human disease, and in Australia we really just see B, C, W, and Y. A and X are really limited to Africa, although in Australia in the 80s and 90s there was invasive meningococcal disease and meningococcal conjunctivitis caused by serogroup A in Aboriginal people. So somewhere between 3 and 25% of the population carry Neisseria meningitidis in their throat, and this is age dependent. It starts off very low, around in the infancy, and rises gradually through adolescence and peaks usually in, if studies are done in college-age students or military barracks recruits, where up to a quarter of the population of those young adults can carry Neisseria meningitidis in their throats. And then as people age, this drops back off and becomes quite low in older people as well. So the bug's transmitted by respiratory droplets from person to person, so it does require fairly close contact or close and prolonged contact. So usually intimate kissing, sexual partners, or amongst in households with frequent interaction. So it's not spread by just sharing drinks, although there is increased transmission for people who share bongs and other drug paraphernalia. Next slide, please. So just before we go any further, just to make it clear what we're talking about. So invasive meningococcal disease is when we isolate through culture or detect through PCR the bug from a sterile site. And then carriers are those persons with asymptomatic colonization of the bug in their throat. And then a contact is a person in contact with a case 7 days before the case's onset of disease, or up to 24 hours after, up until 24 hours when a case has had effective antibiotic therapy, which can mean that sometimes healthcare workers or other patients may be exposed to the infection, may be classified as contacts. Next slide, please. So we'll spend a bit of time looking at this, and this is from the Commonwealth Department of Health, and this is some work that's being done in consultation with CDNA, prompted by the increase of meningococcal W that we've seen in Australia the past couple of years. But there's a lot of information in this slide, so it goes back to notified cases of invasive meningococcal disease across Australia since 2002. And the colours indicate the serogroups. So the reddish colour is meningococcal B disease. The green is C, the purple W, and the orange is Y. So we can see that in the bit over a decade from 2002 to 2013, there was a very marked reduction in incidence of invasive meningococcal disease from around 700 cases per year in 2002 down to only around 200 cases in 2013. And this is largely attributed to the introduction of the meningococcal C vaccine in 2003. So that was introduced at 12 months of age, but there was also a catch-up for people up to 19 years of age then. So there was a rapid increase in immunity in the population, and you can see that after 2003, meningococcal C disease has virtually disappeared in Australia. Now, obviously, meningococcal B has been present through this whole period at similar and then eventually at much higher levels. But the meningococcal C strain that we had back in the 90s and early 2000s was caused more severe disease than we see from meningococcal B. And it was clonal complex type 11, which is what we've now seen emerging with meningococcal W. So this is a clonal complex that causes much more severe disease, so a higher case fatality rate and more morbidity than meningococcal B causes. So after reaching a low point in 2013 with only 0.6 cases per 100,000 population, up till the end of October, I think this is, 2017, we've more than doubled our incidence rate up to 1.6 per 100,000. And that's around about 400 notifications so far this year. And most of that increase has been due to the increase in meningococcal W disease. But there's also, you can see, been quite a large increase in meningococcal Y disease. So those are the main things to take. We rarely get meningococcal A, and the non-groupable or non-grouped was high in the early periods when the laboratory confirmation wasn't as consistent, and it looks a little high in 2017, but that will be reduced because pretty much all those isolates will eventually be subgrouped. Okay, so next slide, please. So this slide again is from the same report, which shows the distribution of notification rates by age, and looking at the difference between Indigenous people and non-Indigenous people. And this is across this entire age period as well. And you can see a very large discrepancy in the notification rate per 100,000 for Indigenous children, particularly those under 5 years of age, but also Indigenous children under 10. But then by the time adolescence sets in, the rates are pretty similar for the rest of the lifespan between Indigenous and non-Indigenous people. Next slide, please. And so this is looking at, again from the same report, it's looking at the notifications by age group, by serogroup. So you can see very different pattern, and this is just for 2017, so if you looked at other years, it wouldn't have looked quite like this. If we'd looked back in 2013, for example, the under 1-year-olds and the 1 to 4-year-olds and the 5 to 9s would have almost solely had serogroup B, and we would have only found W and Y in the older age groups. But there's been a very marked change in the epidemiology of the serogroups of meningococcal disease with the emergence of this new clonal complex meningococcal W. So unusually, we're seeing a big increase in the older age groups, but it's also now affecting children, the predominant in children, serogroup in children 5 to 9, and causing a lot of the disease in the 1 to 4. We're also seeing meningococcal Y disease in younger children, which is something that was almost unheard of before a few years ago. So we haven't fully characterized what's happened with the meningococcal Y serogroup isolates, that it is an interesting change in the pattern of the epidemiology we're seeing. You can see there's a smattering of meningococcal C disease, and those cases, virtually all of them are in people who have, for example, weren't in Australia to receive the benefit of the meningococcal C program when they were in their younger years. Okay, next slide, please. And this is another slide from that the Commonwealth Department of Health have put together. So this is looking at the emergence of a subclone of the meningococcal W disease that is affecting Aboriginal people. And so it's started back in 2016 with cases in Western Australia. And you can see them in early 2017, cases in South Australia, and then quite an explosive outbreak spreading into the Northern Territory just in the past few months. And this has been, while I guess the numbers are relatively small compared to the overall meningococcal disease incidence in Australia, given the populations that this is affecting, this has been a very serious outbreak and has prompted a response by 4 states and territories with vaccination. We'll look at that in a minute. Next slide, please. So, what do we do to prevent meningococcal disease in Australia? So as I said before, we've had meningococcal C disease on the National Immunisation Program at 12 months of age. And for the past few years, that's been given as part of a combined vaccination with the 4th dose of Haemophilus influenzae B vaccine, and that's called highrisk. And in response to the very marked increase in meningococcal W disease that was seen in 2015 and 2016, in 2017, 5 states and territories, 5 states have been offering the conjugate meningococcal ACWI program to adolescents. It varies a bit across the states, but it's basically targeting adolescents from 15 to 19. And the reason for using this vaccine in that group in response to this very rapid increase of meningococcal W disease is that what we talked about before, the peak carriage rates being in young adulthood. So by vaccinating this cohort, it's hoped that you'll give individual protection to these young people as they're entering in their peak risk period for meningococcal disease, but also have some kind of impact on community-wide spread of meningococcal W. And I mentioned a couple of times there, those 2 vaccines are both conjugate vaccines, and they're the preferential meningococcal vaccines to use. There's also meningococcal polysaccharide vaccines that are still available, but they're less, while they're cheaper vaccines, they're not as preferred because they don't give the long-term protection that the conjugate vaccines give. And then, as I mentioned, just in the past month or 2, programs targeting Aboriginal people in Central Australia and in communities with cultural or mobility links to Central Australia have started in South Australia, Northern Territory, Western Australia and Queensland. These vary a bit depending which state you're in or territory, but they're mainly targeting 0 to 19-year-olds, and they're being run out by prioritising first off the communities that are already most affected by the outbreaks, and then gradually spreading out to affect other communities that have links with the affected communities. And this is to try to get ahead of the outbreak because, as we saw from an earlier slide, this strain of meningococcal disease affecting Aboriginal people first started in, well, the Kimberley, then Kalgoorlie, then Ceduna, and then moved up to the Central Australian part of the Northern Territory. So it's clearly moving from community to community. So there's certainly a strong desire to vaccinate as many Aboriginal young people as possible to try and get ahead of this outbreak spreading to other communities. Next slide, please. Okay, so now we move on to the response to a sporadic case of meningococcal disease. And of course, this is all drawn from the National Guidelines for Public Health Units, the Invasive Meningococcal Disease Song. And I'm sure that you're all familiar with the series of national guidelines from CDNA. So we have the invasive meningococcal disease is one of those. So a sporadic case, so this is a case that's just arises in a community without any other cases that the case was exposed to. So it's an urgent public health response to a case of invasive meningococcal disease and also to cases of meningococcal conjunctivitis. So we haven't really talked about that yet. So meningococcal conjunctivitis is a severe form of conjunctivitis, and so if proven by swab, confirmed to be one of the serogroups of meningococcal disease that's causing the conjunctivitis, the response to the contacts of that case is the same as for a case of invasive meningococcal disease. And that's because the risk of secondary cases in contacts of meningococcal conjunctivitis is similar to the risk of secondary cases in contacts of invasive meningococcal disease. So while meningococcal conjunctivitis isn't counted as cases of IMD, the public health response is the same. So basically, the public health response on notification is to identify all the contacts, to arrange clearance antibiotics and information to high-risk contacts, and arrange information to low-risk contacts. So we'll go through those elements in the next few slides. Next slide, please. So who are high-risk contacts? So basically, we're speaking about household or household-like contacts. So household contacts are those who live in the same house or a dormitory type room, for example, a boarding school room, or we're having an equivalent degree of contact with the case as a household contact in 7 days prior to the onset of the case's symptoms. Intimate kissing and sexual contacts are fairly self-explanatory, and that's also the same time period. Now, childcare contacts, now this has changed when the song was updated earlier this year or last year. So it's children and staff in the same childcare group that have an equivalent degree of contact with the case as a household contact. So basically this is said to be around 20 hours in the 7 days prior to the case's illness, and usually at least 4 hours a day for 5 days, or approximately 2 days of full day childcare would, if all the children in that care group would be considered high risk contacts. Then passengers in long distance travel, so at least 8 hours or greater by any form, if it's a passenger seated immediately adjacent to the case who then goes on to develop invasive meningococcal disease within 7 days. And then healthcare workers, but only if they have unprotected exposure to the nasopharyngeal secretions of the case. So this is if they have intubated the case without wearing a mask, or there's been a vomiting incident, something like that, that's when healthcare workers are considered high-risk contacts. And we do try very hard to carefully delineate which healthcare workers have had higher exposure. So hopefully most cases of invasive meningococcal disease will be managed without any high-risk exposure of healthcare workers if appropriate PPE is being used when the case is presented. So next slide, please. So the importance of carefully defining high-risk contacts so that the clearance antibiotics can be, in particular, can be appropriately targeted. So it's really important as the public health manager of an response to invasive meningococcal disease that clearance antibiotics are limited to those people who are at high risk of going on to what we'll talk about the purpose of clearance antibiotics. So it's very, very important that they're limited to high risk contacts. So the most recent iteration of the therapeutic guidelines preferentially uses ciprofloxacin as clearance antibiotics, and that has the benefit of being a single-dose oral course. So just if it's an adult, it's 500 milligrams stat oral, and there's obviously weight-based dosages for children. There's been a few, it's been a little bit controversial because quinolones have a relative contraindication in children under 12 because they can interfere with cartilage maturation, but it's now been agreed in the therapeutic guidelines that that's not a consideration for a single dose and a response to in a contact of meningococcal disease. The other difficulty with ciprofloxacin is that pediatric dosing is not available, so syrups are not available in Australia, but a number of public health units do get child-friendly doses made up from the oral capsules. Rifampicin is easier to use in children in that syrup is more readily available, but does require 4 doses over 2 days. So usually the first dose will be given supervised in a clinic, for example, but the other 3 doses rely on the parent completing the course, and it does have the adverse effect of turning the urine and other secretions a pinkish colour, so that can be unusual. Otherwise, it's pretty straightforward to use in children because we rarely encounter children with significant liver disease or other drugs that will interact with rifampicin. We need to use ceftriaxone for pregnant women, as ciprofloxacin is contraindicated in pregnancy, and the downside of ceftriaxone is that it needs to be, it's an intramuscular injection and needs to be given with lignocaine because it's very painful. Now, the first thing on the list there is information, and this really is the most important thing for any contacts of meningococcal disease. These high-risk contacts need to be, first off, reassured about the level of the risk, but they also need to be aware that they, despite taking clearance antibiotics, they are at an increased risk of developing meningococcal disease in the following days and weeks, and they need to know the signs and symptoms of meningococcal disease, and they need to know what to do if they develop those symptoms. So it's important that they receive written information that they can take with them and be encouraged to present to the GP or emergency department if any of the contacts develop signs or symptoms of meningococcal disease. It's also important to explain to them the purpose of clearance antibiotics, which I think we get to in another slide, which is not about preventing disease in the individual, it's about preventing the carrier state in the probable source of infection for the case that's just occurred. And the final thing, once the serogroup's confirmed, and if it is a case of A, C, W, or Y, then the household or household-like contacts should be offered vaccination. So this is a subset of the high-risk contacts. So, for example, the travel contacts are not included in as being recommended to have vaccination. But for example, if it's a case in a childcare centre and it's due to A, C, W, or Y, then those the care group in the childcare centre would be recommended to have vaccination for the relevant serogroup. And that's, as we discussed before, it's a combination vaccine, so that would be preferentially used if there were any, if it was due to one of those serogroups. Okay, next slide, please. Okay, so this is just going through the rationale for clearance antibiotics. So, yeah, we might have to put it all out. Thanks, Brittany. This is an animated one, makes it difficult to do. Okay, so this is looking at the potential transmission pathway of the meningococcal bug. So we have our case, which is a sporadic case. Now, after onset, they could spread that bug to other contacts, which it would usually be healthcare workers. And so in that case, we would give clearance antibiotics to healthcare workers who'd manage the case without, with unprotected airways. But the remainder of the clearance antibiotics, I think if we just go to the next click, please, Brittany. The rest of the clearance antibiotics are about finding amongst the cases group of close contacts who the carrier may be. We don't test for that. We just give clearance antibiotics to all the close contacts, and the purpose of that is to stop whichever contact transmitted the meningococcal bug to the case, to prevent them spreading it to other people, so to prevent other secondary cases amongst that contact's contact network. So I think we're done with that slide now. So low-level contacts. So these are classmates in primary school, high school, or university. They might be work colleagues, sporting team members, social groups, people at parties and other places, and healthcare workers who haven't had exposure, unprotected exposure to nasopharyngeal secretions. Now, because these people are all potentially contacts of the source contact who gave the infection to the case, they are at risk of developing meningococcal disease. They're not given clearance antibiotics because they're not suspected to be carriers, but they are at an increased above normal risk of developing meningococcal disease in the coming days or weeks. So they also require information, and it's preferable that that information is written and explained to them, the signs and symptoms of meningococcal disease and what to do if they develop symptoms. And it's also useful to explain to them the purpose of the clearance antibiotics and the reason that we're not recommending clearance antibiotics for these levels of contacts, because they're not suspected to be carrying the bug, but they may have been exposed to it, in which case they need to look out for signs and symptoms and know how to respond. Next slide, please. So the timeframes for these actions. So the initial information and clearance antibiotics for household contacts should be commenced on notification. So once we know that a case has gram-negative diplococci and they have a consistent clinical picture, that's a confirmed case, so obviously that should be actioned. But even when they present with, for example, a particular rash and fever and sepsis, then that would be very reasonable to start giving clearance antibiotics for the household contacts at that stage. The other contacts, particularly if there's large groups, childcare and so forth, we should wait until the diagnosis is confirmed. So that means having gram-negative diplococci identified, or a positive PCR or a positive culture in the right clinical setting. Now, the exception to this may be in some remote areas where there's going to be a significant delay in getting the diagnosis confirmed, and it may then be reasonable to go ahead and initiate post-exposure clearance antibiotics in response to a probable case. Next slide. Yeah, thank you. Okay, so this is just an interesting case that we've had recently in New South Wales, and I thought I'd run through it because it illustrates some of the issues around cases in childcare centres. So the first case is an 18-month-old female who'd been previously well and had an onset of fever, vomiting, reduced appetite with no rash on the 1st of September, and she rapidly became unresponsive. And she was transferred to the Sydney Children's Hospital from Royal North Shore via neonatal emergency transport after she had a seizure at North Shore Hospital. Next slide. She was moderately unwell on examination. She had a high heart rate and high respiratory rate, and she had a fever and ED, and high white cell count and CRP, and abnormal CSF. Next slide. And sorry that she grew from her blood culture Neisseria meningitis, and it was found to be type serogroup B. So on to the next slide. So the second case is a 13-month-old male, and who'd also been previously well and had an onset of the 1st of September of fever, vomiting, a non-blanching rash. He was lethargic with poor oral intake. And he presented to a different emergency department, very flat and just not eating or drinking. Next slide. Also, you can see not that febrile in the emergency department, but also had a high heart rate, respiratory rate, and, sorry, can we have more revealed? Again, a high white cell count and abnormal CSF. And next slide. His blood culture and CSF culture were negative, but he was CSF was PCR positive and later found to have, again, a serogroup B Neisseria meningitis. So both on the same day, but in different parts of Sydney. So next slide. And they were both isolated and treated. Thank you, sorry. So these are in the same age group. Same day of onset. They were about 15 kilometres apart. Both in two separate public health units. The public health units immediately commenced investigation of these two cases. Next slide, please. So the contact tracing found that both cases attended the same childcare centre in a third public health unit in Sydney local health district. And it happened that the mother of case one was also a childcare centre taught at the same childcare centre that the two infants attended. So follow-up was coordinated across the three public health units, Northern Sydney, South Western Sydney and Sydney LHD. Next slide, please. So, so the response here. So we've got 2 cases of meningococcal disease within 24 hours of each other. So those are classified as co-primary cases, which is an important distinction in actually counting the cases and determining the response in the childcare centre. So if we can, if they had been onset more than 24 hours apart, one would have been counted as a secondary case. So we know that then that it's highly likely that the source of these 2 infants' infection was at the childcare centre, one of their close contacts. So the purpose of clearance antibiotics in this case, as with in all others, is to prevent that contact spreading that strain of meningococcal disease to others, because we can already see that it's a rapidly invasive strain. So the public health units organised to give clearance antibiotics to the care group of those 2 infants, so they're both in the same care group, and so all the other children and the staff that are in that same care group, in order to eliminate carriage from the presumptive source of these 2 infants' infection. I think we've got a little bit more on this slide. Yeah, so that's great. So next day, the public health unit ran a clinic at the childcare centre. So there were 13 children who satisfied the criteria as having spent around 20 hours in the 7 days before onset in the same care group, and they were commenced on rifampicin. There were 5 staff who'd worked at least 20 hours in the same room during the 7 days, who received ciprofloxacin, and there was another staff member who was pregnant who required intramuscular ceftriaxone. There was no hospital staff that were exposed to the secretions, and then all the remaining parents and staff at the centre were provided with information, and because it was type B, vaccination was not indicated. So we actually haven't discussed this already. This is, so we do have a vaccine against meningococcal B, the Bexsero vaccine. It's not on the National Immunisation Program, and it's not indicated for sporadic cases, contacts of sporadic cases of serogroup B disease. And this is because it's not a conjugate vaccine. It's a, forgive me, it's, the word will come to me in a moment. Anyway, it's a type of vaccine that requires at least 2 doses, and in infants actually 4 doses to provide full protection. So in the context of preventing cases amongst contacts of sporadic meningococcal disease, it can't be given, a sufficient immune response wouldn't be developed in a timely enough way to prevent disease in the contacts. So the spacing of the vaccine is at least 2 months between doses, and the high-risk period amongst the contacts is usually up to 4 weeks after the index case. So we have received advice from the Australian Technical Advisory Group on Immunisation that for sporadic cases of serogroup B disease, even though it is vaccine preventable, vaccinations are not indicated for those contacts. It would be a different matter if we had, for example, a college, university type outbreak or a boarding school outbreak of meningococcal B disease. And certainly in the United States, there's been a number of outbreaks where meningococcal B vaccine has been used in institutional outbreaks, and we'll talk about those in a minute. Next slide, please. So moving on to outbreaks. So there's two types of outbreaks that we look at. So there's organization-based outbreaks. So as just mentioned, it could be in a boarding school, it could be in military barracks, in any, or even not necessarily a boarding school. It could be in a primary school. So where there's some kind of organisation that can be identified when there's 2 or more cases in a 4-week period. Now, in counting those cases, we don't count co-primary cases or secondary cases as separate cases. So if you have 2 cases onset on the same day, that's not an organisation-based outbreak, or even a secondary case. So if it happened within a week, that wouldn't be. But if there was cases separated by more than a week that were not amongst the identified close contacts, then we would need to do a response in that organisation. And the response there is mainly that clearance antibiotics go to a much wider group, and that's because it's hypothesised that there's been much wider carriage of the invasive strain, so that it's important to clear that bug from this organisation. I think there's another point on this slide that we looked at community-based outbreaks, which are defined as, Brittany, can we have another click? So community outbreaks are 3 or more cases in a 3-month interval in the general community. But in Aboriginal communities, if we get 2 or more within 4 weeks, then that also meets the criteria for a community outbreak. So communities can be a little harder to define depending on where they are, particularly in cities. But the rule of thumb is the population attack rate should exceed 10 per 100,000 to be classified as a community outbreak. And the response to a community outbreak is vaccination of the affected community. And again, that's a very major thing to happen, and apart from the response that we're seeing in the Aboriginal community at the moment, it's a very unusual circumstance to happen in Australia. Next slide. Yeah. So that brings me to the end of the presentation I prepared, and I'd like to acknowledge Nick Rose and Nathan Saul from my team here, who helped with some of the slides, and also particularly Christina and Jenny from the Office of Health Protection, but certainly others in there that are pulling together these monthly reports on invasive meningococcal disease in Australia that are available on the website link I provided there. So I don't know if we have any ability to have any questions or anything on this.
But we could schedule that meeting.
Does anybody have any questions this afternoon?
I can use your room link. Yeah, because the reason I said that, because if we start.
Yeah.
Doesn't sound like it.
If nobody has any questions this afternoon, I'd like to thank Vicky for this great presentation, and we hope to see you guys next year. Have a good Christmas. Thank you.
Okay. Thanks, Brittany. Bye.